Hi, this is Paul Rosengren, and this is Dr. Adam Jarrett, who is the CMO of Holy Name Hospital. Together we wrote the book, In the Time of COVID, One Hospital's Struggles and Triumphs. And I have been collecting questions for, I'm going to call him Adam, because he's a friend. Questions for Adam from Facebook, my Facebook, also In the Time of COVID's Facebook. And if it's okay, we're going to get right into it. So Adam, how are things today at the hospital, and how is it different from the first wave?
So Paul, thank you, and good evening, first of all. So things are very busy at the hospital, but dramatically different than they were in March and April. So we are seeing a significant number of patients in the hospital with COVID. We currently have approximately 65 patients in the hospital with COVID, and that includes about 6 patients that are on ventilators. The second wave has been more of a up and down wave without a daily increase in cases like we saw back in March and April. Back in March and April, we peaked at about 250 patients with over 45 patients on ventilators. And so it's been an easier time, although we're still very busy with COVID. And we've been able to do a much better job because we're better prepared because of all the facility changes that we made during the first wave. So all our COVID patients are isolated in separate wards from our non-COVID patients.
So Adam, to me, there's a very different feel from the first wave. Coming down Route 4 in the middle of the first wave was, there'd be no cars, all the parking lots would be empty. Coming down tonight to Teaneck Library, there was traffic. And there was, looking into the Diamond Exchange, which is a store with a big glass front, you could see quite a few people inside and cars in the parking lots. Are people getting cavalier about this? Should they be more concerned?
So I don't think so. I think that everyone needs to follow good social distancing rules. And back in March, I was a strong proponent of a very strict shutdown. And the reason that I made that statement and pushed that approach back in March and April had to do with the fact that the hospitals in the northern New Jersey area and in the New York City area were really close to being at capacity and close to being overwhelmed. And I was very concerned that patients who needed acute care related to COVID or related to some other illness would not be able to access the healthcare system. And we're just not at that stage right now in northern New Jersey, thank goodness. The hospitals are all very busy. We're staying in touch with each other on a regular basis, so we're all dealing with a significant number of COVID patients, but nowhere near the volume of patients we had back in March and April. And therefore, I don't think we need or can afford as a society the kind of shutdown that we absolutely needed in March and April. Keep in mind that the shutdown was never really about trying to prevent every single case. That's just not going to happen, unfortunately, with this disease. The shutdown is about preventing enough cases so the healthcare system doesn't get overwhelmed.
Adam, I think you wouldn't be surprised that probably the questions I got, the subject I got the most questions on was vaccinations. It's obviously a big thing in right now in a lot of people's minds. So the first question is, have you been vaccinated?
I have. I've received both my first and my second vaccine.
And are most of the people at the hospital vaccinated? How is that going?
So we're doing a terrific job at Holy Name vaccinating any of our staff who wants to get vaccinated, and thank goodness the vast majority are interested in getting vaccinated. Unfortunately, at Holy Name and throughout other places in the country, there's still a small group of people who are reluctant to get vaccinated, and if you walk away from tonight's discussion about our book with anything, it should be about the importance of making sure that when the vaccine becomes available to the general public that you go out and get it. This vaccine has proven to be safe. We know what the risk is of not taking the vaccine, and so I encourage people to take the vaccine, and I am pleased to report that we have had no significant complications from the vaccine at Holy Name, nor have I heard of any complications from people taking the vaccine in any of the northern New Jersey hospitals.
So Adam, why is the vaccination program going so badly? It just seems like we're prepared for this. We should have been prepared for this. We knew it was coming for quite some time. Why is it going so poorly?
So that's a 3 or 4 part answer. It starts with the fact that there is still a limited supply of vaccine. And unfortunately, in the middle of a pandemic with a new disease, with a newly developed vaccine, which, by the way, is miraculous. We've never before, as a society, as a world, been able to develop a vaccine at the pace that we did with the COVID-19 vaccine. So that in itself is miraculous. But it still takes time to make as much vaccine as we need. So there's still a problem with capacity and the amount of vaccine that we have available. And I do think that we need to do a better job on a national level to make some decisions about widespread vaccinations and to set up other vaccination sites besides the hospitals, which are the main vaccine site in northern New Jersey. And I think some of the pharmacies have stepped in. But we really need a national movement, even with the help of potentially the help of the military or the National Guard, to create vaccination locations that are providing vaccine. And I'm optimistic that we're going to do that once there's adequate amount of vaccine available.
And what is the time frame on this? I mean, I've read reports that it could take, 9 months to a year to get everybody vaccinated. That I also heard that we did 50 million vaccines for a different disease in 2 months. So what is a realistic number, do you think?
I think that we're likely talking about 6 to 9 months to get enough vaccine out to people that we reach that number of vaccinated people where we can be confident that there is herd immunity, where we can go back to not a COVID-free life, but a pandemic-free life, and that we can go back to the normal things that we need to do, live without masks, go to restaurants, go back to work, go back to face-to-face life. And I think we're 6 to 9 months away from that, just because it is a major undertaking to vaccinate the hundreds of millions of people that we need to do in this country to make that happen. And we still have to deal with the reality that there are people in the country who are reluctant or unwilling to take the vaccine. And we could do everything right. And unfortunately, if there's enough people like that, we could have a problem and may not be able to go back to some sort of normal existence that we all expect to do once we have enough people vaccinated.
So Adam, one of the things about vaccinations I don't quite understand is why after you've been vaccinated and you are, quote, immune, or 90% immune, 90% of the people are immune, why do you still need to wear a mask? Why are they saying you should wear a mask for some time into the future?
So there's several answers to that question. And a lot of it has to do with the fact that this is a new disease that we are still trying to understand. The first issue is that it doesn't create 100% immunity. And until there is adequate herd immunity, everything we can do to prevent an infection, such as wearing a mask and social distancing, is a necessary part of what we need to do to keep everyone safe, because the vaccine, unfortunately, is not 100% effective. The second, more concerning issue is we don't know whether the vaccine prevents you from getting the disease or whether the vaccine prevents you from getting the disease in a way that makes you sick. So it is at least theoretically possible that you could get the vaccine, get infected with COVID-19, not be aware that you're infected because you just don't get sick because you have good immunity from the vaccine, but then still spread the vaccine to other people. So therefore, the vaccine is protective for each of us as an individual, but it may not be protected for the people around you until they've also gotten the vaccine. And so in the meantime, we need to wear masks and socially distance.
Thank you, Adam. I think that also illustrates what we hope to do in this book, which is take something that's being said out there and make it a little bit more understandable for everyone. And I think that was one that I needed a little bit more understanding. Thank you. So I think one of the things that this book does is explain tough medical information. There is a whole section on vaccines and Adam's point of view looking towards the end of the first wave on vaccines. But there's also a lot of good stories that kind of keep grounding you in the fact that this is more than just about a medical crisis. It's also about human beings. And so I'd like you to read a couple stories today, but let's start with one of my favorites, which is about your talking baseball experience on page 47 if you're reading from home. I'll let you pull that up.
So before I start reading, I'm trained as a primary care doctor, and I practiced primary care medicine in northern New Jersey for about 15 years before I became a full-time administrator. And one of the things I prided myself on is being able to explain to people in non-medical talk what's going on with their body and with their health. And that's one of the things that Paul and I tried to accomplish in this book. I hope we did that. I hope you all give it a chance and and you can use this book to learn more about COVID-19 and how one hospital dealt with it. And here's an example of one of those stories and the way that Paul and I together try to explain some of the things that COVID-19 does to us as individuals. When our publicist, Jessica Griffin, asked if I wanted to be a guest on Ed Randall's Talking Baseball, I quickly said yes. I've always enjoyed listening to the show. She added just as quickly that I would not be on to talk about baseball. The episode would be strictly COVID-19 related, and Ed's regular audience could call in and ask questions about the virus. I was a little disappointed. I've been a baseball fan my whole life. I grew up watching professional games with my father, and I played Little League. When I was 9, I had a particularly great coach. He loved the game. He was extremely competitive, and his team always won. As it turned out, he would later become my father-in-law. I probably ran into my wife that season. She would run around the park while her father and brothers were on the baseball field, but neither of us remembered the other from that time. However, 8 years later, when she told her parents that we were going on our first date, her father definitely remembered me. Nice kid, lousy baseball player. Still, I loved the game. The day I appeared on Talking Baseball, Ed dove right in. There's never been anything like this in our country in the past 100 years, he started. It's been a week and a half since the World Health Organization declared coronavirus a global pandemic. After he detailed the exponentially rising case count in New York City, it had more than quadrupled in a matter of days, and New York City had about 30% of the country's cases at that time. He introduced me as the episode's lead-off hitter. I have to admit, my stomach fluttered. After Ed and I spent a few minutes discussing COVID-19 and how Holy Name was handling it, he opened up the phone line for questions from listeners. At first, I fielded what was becoming standard COVID-19 questions. How can I avoid getting it? Can I visit my relatives? Can I travel? What's going on at the hospital? And then we got an unusual call. My daughter said she has COVID-19 toes. Is that a thing? My first instinct was to say that was crazy, but I refrained, which was fortunate. Instead, I told the caller that I wasn't familiar with the condition, but would do some research. At the time, good medical information on COVID-19 was scarce, even in the medical journals. When I finished my appearance on Talking Baseball, I Googled COVID toes to see what would come up. And there they were, pictures of very red, inflamed toes. Unlike gout, which affects the big toe, COVID toe appeared to mainly affect the little digits. I was genuinely surprised and really glad that I had not told the caller that COVID toes were ridiculous. When I got to the hospital later that day, I asked the nurses if they had seen COVID toes. Well, they had not seen the condition at our hospital. Michelle said her 22-year-old niece had had a mild case of COVID-19 and did in fact have COVID toes. I asked if I could see them. 2 hours later, Michelle's niece, who had completely recovered except for her feet, arrived at the hospital lobby, where she took off her shoes and showed me her toes. They looked just like the pictures on Google. Although they were red and inflamed, they were not causing her any discomfort, and they later gradually returned to normal without any intervention. My guess is that COVID toes are related to a post-infectious inflammatory process. It seems to occur in patients mostly after the acute infection subsides and may be related to microclotting, clotting that blocks the smallest veins or arteries leading to or from the skin of the small digits. This microclotting can lead to swelling and in some rare cases the need to remove the toe or toes. By the way, my appearance on Talking Baseball garnered more compliments than any other appearance or interview I have done. I heard from family, friends, and coworkers, and even a nun, one of the St. Joseph's Sisters of Peace, and an avid baseball fan.
Thanks, Adam. I just love the way that story gave you some facts, gave you facts about the hospital, gave facts about you, gave facts about the disease, and there's some really good stories, about your time working with AIDS and how that relates to COVID-19, and some real personal stories as well. I'm going to give you a break from talking. I'm going to answer the one question that I can answer, which is, how did this book come about? So back in June, we were having a social distance get-together in my backyard with the Jarretts and with another family. And everyone at the event was peppering Adam with questions about COVID, what was happening at the hospital, what they'd read in the paper. And Adam was answering them very succinctly, very clearly, and putting them in context in a way that I just hadn't seen elsewhere. And I said to Adam he should write a book. And he said, I'd like to write a book, but I need some help. And by the end of the evening, we had agreed to try to see if we could write this book together. And we got together at first every Tuesday and Sunday, eventually every day. And within 6 months, we produced In the Time of COVID, When Hospitals, Struggles, and Triumphs, which for those people who've written a book, 6 months is pretty quick, especially when we both have full-time jobs. But it was fun, rewarding. I certainly learned a lot. And I think you might consider buying it or getting it from the Teaneck Library. You'll learn a lot too. And by the way, on Amazon, which you can read the first 2 chapters without even paying for it. So hope you give that a try. So Adam, another question that I got from a friend was, so what happens with fatalities? It seems, at least in northern New Jersey, the fatality rate is dropping significantly, or at least the number of people dying is dropping from the first wave. But the number of cases may be about the same. So why is that happening? Are we getting better treating people? Or are there different people getting it? What's the reason?
So again, Paul, a very complex question with multiple components to the answer. So we initially thought the mortality of COVID-19 was in the 3 to 4% range, which is actually very high mortality for a viral disease that is likely to affect everyone in the community. I think we've learned that the mortality rate is probably close to 1% or maybe even less than 1%. Not dissimilar potentially from a typical flu season. The difference is that there is no immunity, at least initially, and before the vaccine, to COVID-19. So with that high a mortality rate, the incidence of people dying is going to be quite high. During the first wave of COVID-19 at Holy Name, we lost well over 300 people in a 2 to 3 month period, which is dramatically higher than the number of people that die at Holy Name Medical Center during a typical month. So there is no doubt that the death rate that we were seeing with COVID-19 was much higher than the typical death rate we were seeing prior to the infection. I know there are some people out there that think the numbers are elevated. That is just not the case. This disease has killed well over 350,000 people and unfortunately likely to kill close to 500,000 in the country before we're done. I think that the reason that we think that the mortality rate is going down now is twofold. One is not that the rate is going down, but we're doing a better job testing. And if we're doing a better job testing, we're going to have a better knowledge of the number of cases that are in the community. And therefore, we're more accurately able to reflect what the true mortality rate is, which is probably close to 1% or less than 1%. And it probably was in that range during the first wave. We just did not have the ability to test everyone like we do now. That's the first thing. And the second issue is we probably are doing a better job treating patients. In fact, I know we're doing a better job treating patients. Unfortunately, we don't have a cure, but we have a number of treatments now. We certainly know how to manage lots of aspects of patients who come in acutely ill with COVID-19 at Holy Name and around the country. And so thank goodness, although the mortality rate is small but still significant, it is down not just because we're testing more people, but because we're doing a better job treating this disease. That doesn't mean we should be cavalier about this disease. This disease still has significant mortality, even with the increased knowledge that we have about how to treat it.
So in the book, on page 127 actually, you go through the different stages of COVID and what treatment you would like yourself if you had COVID for each of those stages. I think it's really helpful for anybody who has COVID or knows somebody who has. But has that advice changed ever over the time?
I think if I remember correctly, we actually admit in the book, Paul, that by the time people read this book, some of those things could change. I actually don't think as of yet they have, although I do want to tweak some of what's in the book now, and maybe if we ever write a sequel or if we write a epilogue, we can talk about that a little bit. But there's a couple of things that I think are being fully flushed out now. Number one, I think that We talk a little bit about the monoclonal antibodies, and I think that at the time of the printing of the book, the benefits of monoclonal antibodies were not as well worked out as they are now. I am convinced that of all the treatments that we have today, that early treatment with monoclonal antibodies is likely the most effective thing. Now, the scientific evidence on that is still a little bit lagging behind, but I think when all is said and done, the monoclonal antibodies, which we now have several different types of them, are going to be the thing that are going to most likely prevent people from getting so severely ill, because the treatment with monoclonal antibodies is extremely important that it's done early in the course of the disease, because it seems to work best for patients who don't have a good natural antibody response. And so we've given that treatment to hundreds of patients at Holy Name. On a daily basis, we're treating anywhere from 5 to 20 patients with monoclonal antibodies. This medication is now only approved for outpatients with the disease because it needs to be given early in the course of the disease. So if I had to write that chapter over again, I wouldn't change the order of the treatment, but I would push harder the need for monoclonal antibodies. That's the good news. The maybe not so good news is that I'm a little less convinced that remdesivir, which we're still using and I still think patients should get, but I'm a little less convinced that remdesivir at the end of the day, which was the antiviral medicine that was initially proven to have some benefit, that the remdesivir may not be as helpful as we initially hoped it would be, although I still encourage patients to be given that medicine, and I'm still not convinced that when given in combination with other treatments, it may not have some benefit. But I'm not as optimistic about the use of remdesivir, unfortunately.
So at what point does a patient ask their doctor, like, I'd like to have monoclonal antibodies? I mean, at what symptoms do they have to have? How far into the disease do they have? I mean, there was some talk that not enough people are getting it because either doctors don't know when to give it or patients don't know how to ask for it, or there was a shortage for a while. I know that might have been some of the driver. But is it available now? And when should a patient get involved and say, can I have this?
So there are several situations where remdesivir might be helpful for patients. We, as the other northern New Jersey hospitals, now have better access to remdesivir. We have quite a bit of monoclonal antibodies. I apologize, I misspoke. So we're in a good place. If we need to give a patient monoclonal antibodies at Holy Name, we have a terrific supply at this point, thank goodness. The most common time to give someone monoclonal antibodies is when they are acutely ill with COVID-19, and that is typically symptoms of upper respiratory infection, almost like a flu type symptoms, runny nose, sore throat, cough, low-grade fever, body aches, but before they are significantly short of breath. In those patients, the monoclonal antibodies have shown to have significant benefit and function as if your body is producing antibodies. So if you're having any upper respiratory symptoms or any unexplained symptoms, testing is better now. You should get a test, and if your test is positive, if you have any risk factors whatsoever for getting severely ill with COVID, and that's any significant comorbidities or any advanced age, you should be offered monoclonal antibodies. And most places are doing that now. The other situation to get monoclonal antibodies is in a study situation, and we have a study now at Holy Name, that if you're not sick, but you're living with someone who has documented COVID-19, we have a study now where we can give you the monoclonal antibodies because you've been exposed to COVID-19 in a family situation, and we're doing research now at Holy Name to try to see whether giving someone monoclonal antibodies before they're even sick, but because they've had an exposure, could completely prevent this disease. And so I encourage people to potentially think about enrolling in that type of study if they've had a COVID-19 exposure.
So I just want to be real clear. If I am experiencing flu-like symptoms, I can go to Holy Name, get tested, confirm that I have COVID, and then I can ask a doctor there to give me monoclonal antibodies? Is that the way it would work?
Yes, but I would say that you don't need to ask for it. The doctors at Holy Name, and I believe at other hospitals that have access to the monoclonal antibodies, will offer them to you if you're someone who would meet the criteria, but it never hurts to ask.
Okay. So obviously we talked about a lot of people dying at the hospital in the first wave, and there is some very heart-wrenching stories in there. about some of the people who did pass. But there are also some uplifting stories. I'm wondering if you wouldn't mind reading one. Again, one of my favorites is, it's page 65. It's about a Union City police officer. And it's one of several very uplifting stories. So I think there's a nice mix here of grounding this in accuracy and getting the sense of how serious and horrible it was, but also some of the successes.
Yeah, and we really had to celebrate those successes at Holy Name and throughout the country, because it was a difficult time, and every time we had a success, we wanted to be proud of that success, be thankful that the patients we were caring for recovered, and this is just one of many success stories we had, but one that was particularly impactful on the Holy Name community. Whenever a patient left the hospital, the staff lined the halls, all in masks, clapping and cheering as the patient rolled by in a wheelchair. One such clap out was particularly memorable. Octavio Robles was a police officer from Union City, New Jersey. He had performed CPR on his mother, who had COVID-19. She did not survive, and shortly thereafter, he came down with the disease as well. He was very sick, requiring intubation shortly after arriving at Holy Name. His family was prepared for the fact that he, too, would probably not survive, but he did. After 2.5 weeks on a ventilator, Officer Robles was able to leave the hospital. He refused a wheelchair, insisting on walking out on his own. As he left the hospital, he was greeted by what seemed like the entire police force of Union City, socially distanced and wearing masks, who had joined the hospital staff and his family for the clap-out. As Officer Robles walked away with his children, his fellow police officers followed behind. Then one came back. Nichelle Luster, the Union City police chief, wanted to address the hospital staff. She told us that the force had already lost one member to COVID-19 and that they had been all but certain that they would lose another. The officers, every one of them, would never forget what Holy Name had done for him and for them.
Thank you, Adam. So I have a question from a friend in Louisiana. I realize she's from Louisiana, which makes no sense for this question. But she wants to know, how dangerous is it to eat inside at a restaurant today if you social distance and you wear a mask when you're not eating? And I'll let you start with that, and there's a follow-up question. Now, realize that she's in Louisiana and can eat outside. It's not in New Jersey, where it is now 32 degrees and you can't eat outside, but we'll leave that aside.
So, risks are relative, and everything we do in life has risks. Some are necessary and some are not necessary. I have not eaten in a restaurant, inside or outside, since March of 2020, because I have decided that even eating outside in a restaurant poses some risk, and in my mind, that's an unnecessary risk. Now, I am not opposed to people who will say, I am willing to take that slight risk and eat in a restaurant outside, because that's very important to me. It's very important for my mental health. It's very important to support the restaurants, and I get all that. Same thing about eating inside. So eating outside is safer than eating inside. Not eating at a restaurant and not gathering is even safer than eating outside. But eating inside without a mask, if you're socially distanced, is slightly risky. If you're not socially distanced, it's very risky. So I can't tell you what you should or should not do. I can tell you that eating inside in a restaurant, where you absolutely have to take your mask off to do that, even if you're socially distanced, is more risk than I'm willing to take and more risk than I'm recommending to my family or friends. Now, some of that depends on where you're living. If you're living in a community where there is not a lot of disease, obviously the risk is lower. If you're living in California right now, I would say the risks of eating inside are extremely high. I would say if you're living in the tri-state area, the risks are high, probably not as high as California now, but they certainly are higher than they were during the summer when things had really quieted down here. So risk is relative. In my view, eating at a restaurant at this point is not wise inside, but I'm not critical of people who are choosing to do that if they're doing that in a socially distant way in a community where there is not a lot of COVID.
So the second half of the question is, when do you think it will be safe to eat inside without a mask?
So I am cautiously optimistic that by the end of this summer, we will be getting back to life where we can do that. And I am very optimistic by the mid to late fall, we will be doing that. So the light at the end of the tunnel is here. We can get through this and we could minimize the impact of this terrible virus. But if we do not follow this advice, we're going to have more death than we need to have. And that's just a shame. And that is why everyone needs to get vaccinated so we can get back to normal. And that is why we need to make wise social distancing decisions.
So have we seen the more contagious version of coronavirus in New Jersey? And maybe you can do me a favor here. What do they mean when they say this version is 50% more contagious? Does that mean, well, tell me what that means.
So I got to take a step back a little bit. So viruses mutate all the time. Literally every day a virus mutates because all the mutation is a single change in what's called a base pair or a base that makes up the RNA or the DNA in a virus. In this case, it's an RNA virus, so it's RNA. And that happens every single day. Unfortunately, some of those changes do something to the proteins on the virus that potentially make it more infectious, which is what's happened with COVID-19. It's not unexpected. If you understand evolution, that's exactly what this virus wants to do. It wants to infect more people because that's what makes the virus thrive. So it's not unexpected. The good news is that as of yet, there's no reason to believe that the increased infectivity increases mortality or makes the vaccine less effective. The bad news is that you are more likely to get infected with the virus, and the more people that get infected, obviously the worse we are. I don't think we really know exactly what 50% means. I think people are estimating and guessing that that's what the number is. But I would say it means that if I have the virus right now, which is extremely unlikely because I was vaccinated, but not impossible, and I was standing close to you, Paul, you're twice as likely to get it if it's the new variant than if it's the old variant. And so we need to be careful. Again, I don't want to sound like a broken record, but it comes back to getting vaccinated so you're protected and wearing masks and socially distancing. So if there is a more infectious virus out there, which there likely is, we are protected as we can be.
Are you concerned about further mutation, that it could be to a more dangerous?
That would be unusual. I mean, anything could happen, but that would be unusual. Again, from an evolutionary perspective, viruses actually don't want to become more dangerous. When a virus kills people off, and this is a very difficult conversation, but when a virus kills people off, the virus dies. It's not good for the virus to kill people off. The virus actually wants to live in you and live in you forever. That's the evolutionary perfect virus. It's the chickenpox virus, which lives in for you forever and later in your life turns into shingles. So from an evolutionary perspective, that is not a favorable change for the virus. So I think it's extremely unlikely, but it is a possibility, and it's something that we have to keep an eye out for, but I think it's extremely unlikely.
So I want to stay with reducing risks for just a second. How do you reduce risks of getting COVID if you have to go to the hospital for a non-COVID reason? What is the hospital doing to protect you? What do you need to do to protect yourself?
So here's the really good news. The hospitals have figured this out, and I can talk specifically about what we're doing at Holy Name. We have COVID waiting areas and non-COVID waiting areas. We know that anyone with any upper respiratory type symptoms or flu-like symptoms need to be treated as if they have COVID until proven otherwise. The hospitals are safer now than they likely ever have been because we are doing a terrific job because we know the risks of not doing that job, separating COVID patients from non-COVID patients. In the hospital, COVID patients are isolated from non-COVID patients. COVID staff are isolated from non-COVID patients. So hospitals are very, very safe. The incidence of getting infected with COVID-19 at the hospital is very, very low. Unfortunately, not zero, but certainly, and we were talking about this before we started this cast today, Paul, your wife was concerned about you coming out and being in an environment where she was exposed to me. And the first thing I said to you was, who's doing the shopping in the house? And you said, you are. And I said to you, well, I still think that going shopping in a supermarket, which is necessary, and I'm not saying you shouldn't do it, is higher risk than going into a hospital, because at the supermarket, you don't know who has COVID-19. At the hospital, we do. And we separate those patients. We put them in negative pressure so the virus cannot escape outside the room. We treat them with staff who's wearing appropriate PPE and who puts on and takes off the appropriate PPE in a safe way. And so therefore, patients without COVID are safe in the hospital.
That's reassuring. So I have two questions about children, or maybe three. Do you think that children will be vaccinated in the future?
I do. I think it's going to be a while. The studies that are required in children are tougher than in adults. There is no need at this point to worry about vaccinating children, because although we know that children absolutely can spread this virus, the good news is that the mortality rate for children is very, very, very low. And so therefore there is not a need to rush to a vaccine for children. But if we're ever going to really wipe this disease out, which should be our goal, we should try to wipe this disease out, because even if this disease lives in small numbers of people over time, it's always going to be a risk for taking off. Then we're going to have to figure out a safe vaccine for children, and likely we will do that over the next several years, and that children will need to be vaccinated, which will protect them, because even though the vaccine, even though the mortality rate in children is very, very low, it is not zero, and therefore we should aim to protect them. But as importantly, by protecting those children, we're going to be protecting the adults that are around them.
How do you feel about schools being open right now?
I think schools need to be open. I think schools need to be open in communities where the COVID rates are reasonable. I don't think they should be open as usual. I think that classrooms need to be spread out. I think that there needs to be some degree of remote learning so we can follow the social distancing rules within schools that we need to in day-to-day life. But this is not a 1 month and we're going to be fine. And if it was, as we were cautiously optimistic it might be in March and April last year, and we thought we could close down schools for a month or two and then go back to normal, then it would be worth doing. But educating our children is too crucial for us to shut down schools completely when we know that we're going to be in this throughout the rest of a good part of this year. So I am in favor of opening schools in a very controlled, safe way with smaller classrooms and a significant amount of online learning to augment the in-person learning.
So Adam, you talked about studies with the previous question on children. And to be honest, I was surprised by the amount of research and studies going on at Holy Name during the first wave, some of which you talk about being very successful and some of it talking about not being successful, and the heartbreak of hoping to have a breakthrough and it not succeeding. And you mentioned one study you're doing now. Are there other studies going on at the hospital right now?
Yes, I'm very proud of the work that our research department has done at Holy Name. And we've always been involved in this type of research at Holy Name, but during this pandemic, my team really, really shined. So we were the first hospital in the world to give monoclonal antibodies to a patient in a study. That's really remarkable. And it's even more remarkable when we realize that to date is probably the still most effective treatment. We were the first hospital in the country to give placental stem cells to a patient with COVID-19. Although the jury's still out on those placental stem cells, some of the preliminary results are actually quite favorable. And we have about 7 or 8 other studies at Holy Name at this point, studies on antiviral medications for the treatment of COVID, studies using medications that boost your immune system for the treatment of COVID, and continuing studies on the use of monoclonal antibodies as well.
I know you weren't studying donated plasma, but I know you were collecting it at one time. Is the hospital still collecting plasma of people who've recovered from COVID-19?
Yeah, we don't have an active process to collect plasma, but the blood banks do. Although I have to tell you, the use of plasma now is likely going to fall by the wayside. Plasma is a potentially effective treatment, although the studies were not as hopeful as we thought they might be. But in the setting of being able to use monoclonal antibodies, which likely do a better job than plasma and are more focused for the treatment of COVID-19, the use of plasma will likely fall out of favor.
Okay, so I'm going to give you a rest for a second, and I'm going to plug the book. It's called In the Time of COVID, One Hospital's Struggles and Triumphs. It's available on Amazon, $6.99 for an ebook and $14.99 for the paperback that you see here. And Adam, the cover is a very dramatic picture of someone in a mask, and there are several other pictures here. Can you tell me a little bit about that picture and these pictures and how they ended up being on the cover of the book?
So we have a very talented photographer at Holy Name. His name is Jeff Rohde, who unfortunately, during the second wave, lost his mom from COVID-19, which is a tragedy. I saw Jeff today, and he seems to be doing okay, but it just goes to show you the impact that this disease has, even on our own family, friends, and coworkers. But Jeff Rohde is a very talented photographer. He's been on the staff at Holy Name for, I think, about 7 or 8 years now, and he's traveled down to Haiti with me, and with our CEO, Mike Marin, and he tries and does a terrific job allowing non-Holy Name people to know what's going on with all the work that Holy Name does. Our work at Haiti, as I mentioned, and during COVID-19, he was embedded in the hospital, and much of the photographs, especially during that first wave that you saw on COVID-19 on the news, was taken by Jeff. One of the things that Jeff began to do, because he's a creative photographer, was to gather black and white photos of the entire employee and medical staff at Holy Name. And he began putting those pictures up to sort of inspire our staff, which was needed, obviously. And when I described those photos to Paul and I showed those photos to Paul, he thought that, or you thought that it would make an excellent cover for the book and potentially an excellent back cover for the book. And we played with that, and we did that, and I actually think it works quite nicely. On the front cover is one of our nephrologists, Clinton Coleman, in his N95 masks. And on the back cover is a series of our staff, all in their appropriate PPE. And I think it's one of the ways that we do a little bit of tribute to them for the hard work that they did by just having those pictures up around the hospital at present and also on the book.
Adam's being very generous, because the first time he came and said, I'd like some pictures in the book, I said no. And he came back again and said, I really think we need pictures in the book. And I said, I don't think we do. I think the story propels itself. And then he showed me the pictures, and I was like, oh, wow, these really help the story. And that was we have about a dozen, maybe 15 pictures in the book. And I think each one helps clarify the story that goes with it, or the information that's going with it. So I feel very comfortable that they're there. I think they really, really do contribute. And it is, having worked at several companies, it is just a real luxury to have such a talented photographer on staff and have had these types of pictures available for us to use. Now, Adam, you mentioned that you went with him to Haiti. Why would you go with the photographer to Haiti?
Oh boy, Paul, that's a long. That question deserves a long answer. So I'll try to do this as short as possible. So Holy Name has partnered with a hospital in Malo, Haiti, which is in the northern part of Haiti, about 20 miles outside of Haiti's largest city, second largest city, called Cap-Haïtien. This is a hospital that members of our medical staff and several of our nuns have partnered with for many, many years. And during the earthquake back about 10 years ago, Mike Marin, Holy Name CEO, was asked to come down to get a feel for the kind of work that was being done at Hospital Sacré-Cœur. And the hospital and the city or the town of Malo was really devastated by this earthquake. And Mike was so moved and made several trips down there and realized that we needed to do something about what was going on in this small town hospital. And ultimately, we ended up making that hospital part of our Holy Name system. Unfortunately, we have not been able to go down over the last year or so because of COVID-19, but we are in constant communication with them. There is a Haitian medical staff down there. We help the hospital financially. We help the hospital with support, with equipment and supplies, and we help the hospital with manpower. Although they have a separate dedicated medical staff, volunteers from not only Holy Name, but from around the country go down for typically a week at a time and support the medical staff down there with the kind of care that is needed. And it's something we're very proud of, and it's the kind of thing that Holy Name stands for, and we do talk about it a little bit in the book. One of the reasons, and this is mentioned in the book, that I think Holy Name did as well as we did during the pandemic is because we've had so much experience in Haiti doing more with less. And unfortunately, during a pandemic, when supplies were short, when knowledge about the disease was low, we had to do more with less. And we had experience doing that in Haiti, and we put that to good use during the pandemic.
So I think you mentioned several times in the book about past experience and how that influenced how you approached as an administrator and as a hospital this new pandemic. Can you talk a little bit about your experience on the working on the AIDS ward and what you learned from that you were able to apply to this situation?
So I did my internal medicine residency training from 1989 to 1992 in New York Hospital Cornell, and it was really right in the middle of the AIDS pandemic. We had begun to understand more about the disease. We had the beginnings of some treatment, but unfortunately, at that time, every single person who was diagnosed with AIDS ultimately succumbed to it. And so there were lots of parallels. I did not want to say the disease was the same or the impact was the same, but the more we talked about those parallels, Paul, we decided that there was a chapter in the book. And a lot of that chapter has to do with my personal experience on AIDS wards in the late 80s and early 90s, the fear that I had and society had dealing with patients with AIDS as compared to what was also a real fear that my staff and society had dealing with COVID-19 patients. Much of that fear comes from the unknown. And as we learn more about AIDS and as we learn more about COVID-19, we know there are things that we can do to protect ourselves. And we just thought that there was enough parallels that it was worth a chapter in the book. And I actually, it's one of my favorite chapters in the book. The other thing that I have to talk about is I trained at a place where many years before Anthony Fauci was the chief resident. And I find it comforting to some level because we always thought very highly of Anthony Fauci when I was a resident at New York Hospital Cornell. And when I learned that he was going to lead the country's stand and fight against COVID-19, I felt reassured by that, the same way as I felt reassured in 1989 and 1990 when I knew of Anthony Fauci and we talked about him in sort of hushed tones in the halls of New York Hospital, but we also knew that he was fighting the AIDS pandemic. And not to say that there are easy answers and that Anthony Fauci had those easy answers and was able to snap his fingers and make this disease go away, but there was some level of comfort that we had someone with his level of knowledge and experience who was leading the way.
And I think it's quite a compliment, Adam, that in the Star Ledger, in a story just last week, described you as New Jersey's Fauci. And I think I kind of relate to that because I think that you do communicate it well and you've been in touch with a lot of people to help educate them. I mean, would you say you were frequently talking to local officials occasionally, or did you talk to congressmen, anybody from the state and that type of thing? Was there a lot of interaction between hospital and elected officials and appointed officials?
Yes, very much so. So my CEO, Mike Marin, was and continues to be in regular communication with the governor, and that's been extremely helpful, I hope, at the state level, so the governor can learn about what's going on at the ground level, and it's been extremely helpful for Holy Name. My main contact has been with Josh Gottheimer, our congressman, who's been incredibly helpful, and to this day continues to listen in to phone calls that we have at least 3 times a week with the other northern New Jersey hospitals, so Congressman Gottheimer can understand the reality of what's going on the ground. And I give an awful lot of credit to him, to the governor, and to all the officials of northern New Jersey and of New Jersey, the entire state, who really are doing what we can do to try to minimize the impact of this terrible pandemic.
So I'm going to go back to some of the questions from my friends. One of them had COVID early on, probably before the first case was even identified. And she wants to know if she really had it. Is there a test to see if she had it? And if not, does it really matter whether she had it or not if she doesn't have antibodies?
Well, it matters from an intellectual perspective, but it probably does not matter from a medical perspective. So the best way that you could confirm whether or not you had COVID-19, if you think you had it before you could get a test, would be to get an antibody test. The antibody test is very, very accurate. It's a blood test. It's an easy test, and it's very, very accurate. And if you have antibodies, the likelihood that you at some point had COVID-19 is extremely high. And so I encourage anyone who's curious from an intellectual perspective to go out and get that antibody test. It's simple enough to do.
If they had COVID, say 9 months ago, would that still show on the antibody test?
So that's the unfortunate part. We just don't know. We seem to think that for most people the antibodies last quite a while, a year or so. But I have seen many situations where the antibodies have gone away quickly. And so everyone's immune response is different. And so I don't want someone to get an antibody test, say it's negative, and then say, oh, I never had COVID, because they potentially could have. But here's the bottom line. It doesn't matter, right? It doesn't matter whether you have or have not had COVID. In either situation, you are potentially at risk for getting infected again, because this is a disease that we know can infect you more than once. And whether you've had COVID-19 or not, you should get a vaccine. And so getting an antibody test to confirm whether or not you had COVID is accurate, but not 100% accurate. And at the end of the day, doesn't change what you need to do, which is, again, sounding like a broken record, wear a mask, socially distance, and get a vaccine.
So Adam, a question from someone. She's talked to a lot of people who've had mild cases. Is there something you recommend they do when you first find out you're positive, but you're not really that sick? Is there any over-the-counter drugs that you should be taking? Do you just treat the symptoms, or is it just rest, fluids? What do you recommend for somebody just finding out they're positive, feeling a little uncomfortable, but not really sick?
So the first thing to do is to quarantine yourself, and to go back for the previous 3 days before your symptoms started, and to reach out to anyone that you had significant contact with. The current guideline is more than 15 minutes of contact over a 24-hour period. So you quarantine yourself, you reach out to your contacts so they can be tested. The first thing to do is to protect the people around you. From your own symptomatic perspective, if you're a healthy person and relatively young, the best thing to do is to stay home and take some Tylenol or some ibuprofen to treat your symptoms and just stay away from people. If you have significant comorbidities, or really any comorbidities at this point, hypertension, diabetes, emphysema, cancer, any significant disease process or medication that suppresses your immune system, even if your symptoms are mild, you should call your primary care doctors and ask or arrange to get monoclonal antibodies. Because unfortunately, we are seeing a significant number of people who start with mild symptoms who can progress. And so if you have any significant underlying disease, you should determine whether or not you're a candidate for those monoclonal antibodies.
So I'm going to get to one last question, but before I do, I wanted to thank the Teaneck Library for inviting us for this authors conversation. They are going to have another authors conversation here on Thursday, the 14th at 7 p.m. It's called From Here to Equality, Reparations for Black Americans in the 21st Century by A. Kirsten Mullen and Dr. William Davide Jr., go to tnucklibrary.org for more information and to sign up. It is a Zoom experience. I do want to also mention that the TNUC Library has copies of our books. So if you want to, you can check it out from them or from other libraries in Bergen County. And if you do, or if you've already read the book, we really appreciate a review on Amazon. That would be very, very helpful. And if you're looking for the book on Amazon, it's In the Time of COVID, One Hospital's Struggles and Triumphs, or you can put In the Time of COVID in either of our names and you'll find it rather quickly. So Adam, last question, just how do you stay informed with all of the myriad of information sources, and sometimes they conflict, and where do you recommend that the average person go to stay informed on developments in COVID? I mean, I think there is a little bit of COVID fatigue, and people seem to be less anxious to learn as they were maybe a couple months ago. But if they are and they want to stay educated, like I imagine most of our viewers, what would they do and what do you do?
That's a great question, Paul, and I'm going to take a few minutes to give you my take on that. And the first thing I'm going to tell people is be very careful about using the internet. So the internet is a great resource, but you cannot use the internet without looking at the source of the information you are reading it from. I can't tell you, as a physician and as now an administrator at a hospital, the number of times I hear people say, well, I read it on the internet, so it must be true. I hope most people realize this now, but there is no editor on the internet looking to make sure that the facts you read, well, the information you read, I don't want to call them facts, but the information you read on the internet is accurate. So please do not blindly go to the internet without looking at sources, looking at the source. And if you don't know what sources you need to go to, then you need to do some more research on those sources. So where do I go? I do go, unfortunately, to some of the newspapers. And we joke a little bit at the hospital, but the way medical research is done now, often there are releases of that research before the research is final. And with a new disease, you want to be abreast of that research. And there is often press releases in the New York Times and the Washington Post and the Bergen Record to see what research is being done and what the preliminary studies what the preliminary results of those studies show. I do that very cautiously because they're preliminary results, but when we're dealing with a disease that is new, that's a necessary way to get information. The best way for me to get information as a healthcare provider is to go to the medical journals. And I still use that as my primary source for medical information. As an internal medicine physician, I tend to use the Annals of Internal Medicine, the Journal of the American Medical Association, the Archives of Internal Medicine. There is a resource that has come out in the last 10 or 15 years called Up to Date, which physicians use. That is an organization and a book that goes to all the different journals and reviews those journals and puts the most up-to-date information in those journals. And so I go to that to get the most up-to-date information about COVID and other things medically. And then I also go to respected peers who are also doing the same thing. And that's how I stay up to date. I strongly recommend that we all stay up to date, but that when you do go to the internet, you look at the source and be very cautious about information that's on the internet, because just because it's there doesn't mean it's accurate. And I know this is frustrating, but the reality of when we're fighting a new disease, we're going to have to be very careful about the information we get and where we get it from.
Thank you very much, Adam, and thank you for watching, and have a great evening.
Thank you, Paul.